Welcome again to another Persiflager's podcast review the infectious disease literature with commentary. This is for the last 2 weeks of January in the year 2008. Remember, if you're sick of this intro, you can skip ahead to the next chapter. This is available on iTunes, and if you like it, being the attention whore that I am, I'd love it if you'd write me a good review. This is brought to you by Puscast LLC, the publisher of the Persiflager's annotated compendium of infectious disease facts, dogma, and opinion, your uber hyperlinked electronic guide to infectious diseases at pusware.com. This is CME accredited, so listen, take the online quiz, then get a half an hour of free CME thanks to Legacy Health System. Because it's CME accredited, I have to mention that A, all the opinions are those of Pusware LLC, and B, I ain't got no conflicts of interests. I have all sorts of other conflicts, Oedipal, for example, but we don't need to talk about this on this podcast. This podcast is a review of the infectious disease literature primarily for healthcare providers, but if you're interested, I don't really care if you listen. Other things I like to plug, don't forget my Quackcast. This is a review of supplements, complementary, and alternative medicine, i.e. scams, available on iTunes. If you like infectious diseases and you want to participate in making the world a better place for all people who take care of infectious diseases, go to idwikibook.org and participate in the writing of the infectious disease wiki textbook. Currently, it is languishing in a probably well-deserved obscurity. And finally, if you're a medical student and want to get a good training in internal medicine, you should check out Legacy Health System and their residency program. Now on to the literature. As always, the references are available online. I've been sick this week. Every time I take echinacea and vitamin C, I get some sort of cold. So anyway, I may not have my usual panache when I give this podcast. First up is some cool pathophysiology that was published in the Journal of Infectious Diseases. We've talked about the chemokine receptor CCR5 in the past. This is the Creedence Clearwater Revival receptor, although I believe they were a quartet, not a quintet. Anyway, it's been discovered that patients who are CCR5 functionally negative are resistant to getting HIV infection, which is kind of cool, but no good deed ever goes unpunished, or in this case, no good mutation ever goes unpunished. There are two diseases now that are worse if you happen to have the CCR5 receptor, as elucidated in the Journal of Infectious Diseases this month. First concerned West Nile virus, and them what have a CCR5 Delta 32 homozygous are much more likely to get encephalitis if they get infected with the West Nile virus. The other is tick-borne encephalitis. And again, if you happen to have that mutation, you're more likely to have severe tick-borne encephalitis. Now, they are looking for CCR5 receptor antagonists to help treat HIV disease. So the good news is we may be able to block HIV. The downside is that some illnesses, such as tick-borne encephalitis and West Nile virus, will probably be worse in those patients. So Willie and the poor boys, look out. So perhaps you're wondering how many people in the United States have HIV. Well, in January of this year, the CDC released data based on blood samples in 12,000 adults between the ages of 18 to 49. They found that about 0.5% of people had HIV. 0.5%. What does that mean? Well, that's 15 million people. Well, even that's sort of hard to wrap your mind around. Now, in this study, 2.6% of African American men and 1.5% of African American female were HIV positive. So let's say 18 million people have HIV disease. That's like the entire state of Illinois or the entire state of New York having HIV disease. That's a lot of people with a bad disease, most of whom probably don't know it. I mean, look around you. How many people live in your state? I live 3.5 million here in Oregon. That means roughly 4 times the population of my state in this country have HIV. It just boggles the mind. We have talked in past podcasts how circumcision decreases the chance of men acquiring HIV from women. The question is whether it would work in men who have sex with men. This study, published in the Journal of Acquired Immunodeficiency Syndrome in December, looked at 1,100 black men and 1,000 Latino men and found that having a circumcision was not protective of acquiring HIV. And this was true not only for the population as a whole, but also subgroup analyses, including bisexual men, those who had unprotected insertive anal intercourse, and those who had protected receptive anal intercourse. Still, I would not be completely dismissive of circumcision as a way to prevent acquisition of HIV. Like all preventative, nothing is 100%, and when you look at the number of receptors for HIV that are found in foreskin, which are truly phenomenal in one study I have seen, it still makes sense that there would be some degree of protection from circumcision for the acquisition of HIV in men who have sex with men. It would be part of an overall more comprehensive preventative, rather than using circumcision as the sole preventative for HIV. By the way, did you hear about the urologist who didn't charge for circumcision? He just took tips. Ba-dum-bum. One of the things to remember about my subspecialty is called infectious diseases. And what is the risk if you are a female from getting HPV if you only have one partner, and it's your first partner? This study was published out of the University of Washington, and they looked at 244 female university students on a longitudinal study to look at acquisition of HPV. They found that the one-year cumulative index of first HPV infection was 28%, and after 3 years was 50%. So that's your risk if you only have one partner. Not unsurprisingly, if the male partner has had multiple other partners, the female's risk also goes up as a result. But just having one male partner and your first male partner means your risk of developing HPV is on order of 30 to 50%. Now, there is fortunately a vaccine that prevents HPV. Evidently, its only downside is it induces hypersexual activity in the females who use it. Isn't that right? I've heard that on some websites. There are, of course, recurrent themes to infectious diseases. No good deed goes unpunished, and use it and lose it. This study came out of Europe, where they looked at 148 samples of this year's influenza A in 10 European countries, and they found that 19 of them were resistant to oseltamivir, i.e. Tamiflu. This should come as no surprise to anybody, but the makers of Tamiflu, Roche, or maybe I should pronounce it Roche, says, quote, no doubts have been raised about the drug's power to combat any deadly bird flu pandemic, end quote. Yeah, because Tamiflu ain't gonna do shit when the bird flu pandemic hits. But that's neither here nor there. My only wish is that those who refuse the routine flu vaccine are denied the bird flu vaccine when the time comes. But not unsurprisingly, there is now some resistance to Tamiflu, and as such, we have no other anti-influenza drugs except vaccines and not inhaling. That's the Bill Clinton technique. I didn't inhale. Works for marijuana, works for bird flu. As you probably noted, I like those articles that have to do with risk factors for disease. We've talked about Legionnaires coming from cooling towers. We've talked about Legionnaires coming from fountains at a restaurant. And this was a case where they linked the Legionnaire's disease in a transplant patient right back to the patient's home shower. And so it's a nice reminder that while sometimes the source of Legionella can be something exotic, you can also get a fatal illness from something as mundane as your shower. A study in the European Journal of Internal Medicine looked at the mundane comparison of bacteremic versus non-bacteremic pneumococcal pneumonia. Now, not surprisingly, patients who are bacteremic were more likely to have liver disease, be a smoker, be a drinker, be an IV drug user, and to be infected with HIV. Patients still had the same mortality rate in this study, whether or not they were bacteremic or not, although if they were bacteremic, they were in the hospital longer and received more intravenous antibiotics. But the take-home message here is that if you have pneumococcus in your blood, or actually your patient's blood, that may be a marker of underlying HIV disease and probably is enough to warrant checking an HIV, especially if they're one of the 15 million Americans who have HIV disease. The study in the annals on MRSA seemed to have caused a brief brouhaha last week because they looked at the incidence of MRSA in men who have sex with men. This was done both in an HIV clinic in San Francisco and a community health clinic in Boston. They found that having MRSA was reasonably common in both groups. In both groups, they were found to have infections that involved primarily the genitals, buttocks, and perineum. In the San Francisco group, 27% of men had MRSA, whilst in the Boston group, 39% of patients had MRSA. So it's not uncommon in the men who have sex with men population in those two cities. I must say that the editors of the annals aren't paying too close of attention because, as they quote in their context, researchers have recently identified multi-drug resistant USA 300, a clone of community-acquired MRSA that is resistant to multiple antibiotics. I wonder why it's called multi-drug resistant. Could it be that it's resistant to multiple antibiotics? The Department of Redundancy Department could even strike at the Annals of Internal Medicine. And speaking of risk factors for MRSA, another one is using intravenous drug. It's injecting drug. You're an injecting drug user, not an intravenous drug abuser. But if you are an IVDAU, whatever, and you are at more risk as a result for developing MRSA. When compared to MSSA patients, your odds ratio goes to 2.11, and when compared to non-infected patients at all, it goes up by 4.09. So one of the many risk factors for developing MRSA is intravenous drug use. I'm going to go out on a limb here and say that that's not a healthful pastime. Treating MRSA still remains a conundrum, and what to do and what the optimal therapy is still in question. Part of the issue with MRSA is that susceptibility to vancomycin can be variable. It can be 0.5, 1, 1.5, or 2 micrograms per mil and still be considered susceptible to vancomycin. A study published in this week's Clinical Infectious Diseases looked at this issue in bacteremia and found that if you had an MIC greater than 1, your odds ratio went up for dying if you had MRSA in your blood. Not unsurprisingly, if you had MRSA in your blood and you were given no vancomycin at all, you really had a bigger chance of dying. Their recommendations are if you suspect a staph infection, particularly MRSA, you should dose your vancomycin up front for troughs greater than or equal to 20, which is a pretty hefty dose, but should be without toxicities up front. They also wonder, as do we all, as to whether the newer anti-staphylococcal agents such as linazolid, daptomycin, tigecycline, or dalbavancin would be better for MRSA, especially if it has higher MICs. I would tend to lean toward using an alternative agent if I had a staph whose measured MIC was 1.5 or 2, especially if they had a serious infection, although the data to support that currently is minimal to none. So the take-home message is if you're worried about MRSA in the bloodstream, give a lot of vancomycin, shoot for a trough of 20, and once you know it's MRSA, if the MIC is higher, especially for serious illness, consider an alternative agent. Now, the other problem with MRSA and staph in general is it likes to cause surgical wound infection. This study looked at patients in a hospital who are going to have elective surgery and were screened for staph, and they found that if they had staph in their nose, their infection rates went up. Their overall rates were 6.4% for surgical site infections, 4% mediastinitis, and 2.2% superficial infections. However, if it turned out they were staph carriers in their nose, their infection rate was 12.5% versus 5%, and the MRSA rate was 33%. Now, the question is what to do about it. Well, it's simple, right? Duh. Your patient has staph in his nose, they're going to have open heart surgery, decolonize them by putting mupirocin in their nose. Would that it was that easy. There's a meta-analysis that looks at the efficacy of mupirocin for preventing surgical infections, and their conclusion is the data does not support the use of topical mupirocin, and in the one good trial for open hearts, it did not show efficacy, although in 2 other surgical wound studies it did. So will decolonization of the nose help in these patients? I would be strongly doubtful that it will. As we've talked about in other studies, MRSA is also carried in the retropharynx and the stool of patients, and I think a better metaphor is not nasal carriage but total body carriage. I consider these patients to be like Pigpen and Charlie Brown walking around in a haze of shedding skin and Staph aureus. I don't know what to do to prevent infections in these patients, and I'm very skeptical that mupirocin is the answer, though it might be part of the answer. A and C, D and B, C only, all the above. One of the issues with daptomycin in the study that compared it to vancomycin for MRSA was the development of resistance to daptomycin on therapy. This is confirmed in an article in the European Journal of Clinical Microbiology and Infectious Diseases, where they looked at 74 treatment courses in 67 patients with staph bacteremia and found that a significant number increased their MIC. What's significant, you ask? 4 out of 74. And those that got increased MICs had a failure of therapy. Now, 4 out of 74 may not seem like a lot to you, but that is a phenomenal development of resistance. And it will probably limit the long-term efficacy of vancomycin, not vancomycin, you idiot. Daptomycin. It will limit the efficacy of daptomycin because if it's used heavily in an environment, one would predict you'd rapidly develop daptomycin resistance in all your staph. Bummer, huh? You young whippersnappers have it so easy today. Back when I was a resident, we had all these meperidine junkies, i.e. Demerol. And meperidine was sort of the narc of choice for people. They come into the ER. Doctor, that Vicodin doesn't work for me. The only thing that helps my headaches are meperidine. Now, why am I talking about this? Well, it turns out that meperidine blocks the reuptake of serotonin. Linezolid, aka Zyvox, is noted to cause higher levels of serotonin. So there was a case report of someone who developed serotonin syndrome when they were on linezolid and meperidine. So add that to your list of drug-drug interactions. It's always an issue as to whether or not coagulase-negative staph is causing endocarditis in your patients, since it's a common cause of bacteremia. Well, just how common is it? In the study out of Clinical Infectious Diseases, they looked at almost 1,700 patients with endocarditis and found that about 7.8% of patients had native valve endocarditis that was due to coag-negative staph and was not associated with intravenous drug use, or as they call it, injection drug use. Now, how is it different than other endocarditides? Well, they had a fairly high mortality rate, primarily due to delay in diagnosis and more comorbid conditions such as congestive failure. Mortality rates were equal to those of Staph aureus. About 25-27% of patients with coag-negative staph endocarditis died. It was 50% roughly nosocomial, 50% roughly were community-acquired, and surprisingly, it was more right-sided than left-sided. My own personal experience is that most of the coag-negative endocarditis I've seen on native valves has been right-sided and associated with central venous catheters. Now, another thing I'm not a big fan of is pets in the Netherlands, and that is the countries in Europe, not the place below your belt. They had an outbreak of MRSA, and it was associated with them what raised pigs or veal calves, and they found that people that did that had a 39% carriage rate of MRSA with subsequent illness. So animal farming can be a source of MRSA. Well, how about regular pets, you might ask? We've talked about MRSA carriage in dogs, but having pets is associated with another infection. E. coli urinary tract infections. Yes, sirree, Bob. In this study in the Clinical Infectious Diseases, they cultured the stool of humans and families, but they also did the dogs and the cats, and they found that E. coli was being spread not only amongst sex partners, but among non-sex partners and between humans and their dogs and humans and their cats. How, you might ask, does a E. coli from a dog get onto a human? Well, I hate to point this out to you, but dogs and cats lick their ass, and then you let them lick you. Ugh, so disgusting. I don't know why people let their animals do that. But if you have a pet therapy dog in the hospital that's recently licked its ass, well, there's the real possibility, though small, that E. coli could go from the pet therapist to the dog to your patient, because it licked its ass, and then you touch the animal. So don't forget that if you have an issue in a family with E. coli, then not only is the humans might be a carrier, but also the dog. And I would suggest that if your dog licks its ass, keep its mouth away from you. Sometimes I wish I was a homeopath. Things would be so much easier, so I wouldn't have to learn anything. This is concerning corticosteroids and septic shock. And in the January 10th New England Journal of Medicine, there's an article that looked at the efficacy of this in septic shock. Historically, back when I was a resident, it was used. Then it fell out of favor because it didn't work. And there was recent studies to show that it might be beneficial at physiologic doses. So this was tested in a large trial and found that corticosteroids didn't help. Bummer. Mortality rates were same in both groups, although the corticosteroid group had a little bit increase in the complication rates due to infection. Now, the downside of this study, according to the editorial, and I'll take their word for it, is that the trial was not large enough to detect small differences. And patients who got corticosteroids got out of their septic state faster, although they died at the same rates. It's always been noted that internists should make sure their patients die with normal numbers, so that may not be a bad thing. So where do we stand with corticosteroids and sepsis? I don't know. I wish I could give you advice. The best trial to date, which is using physiologic hydrocortisone in the New England Journal of Medicine, showed no efficacy. So I'm inclined to say right now that the bulk of data suggests no efficacy. Damn you, science-based medicine! In the same issue of the New England Journal of Medicine, or as they call themselves, the Journal, they looked at the role of intensive insulin in sepsis versus standard therapy. In the intensive insulin group, they tried to get their blood sugars between 80 and 110, whereas in the regular group, they tried to keep their sugars between 180 and 200. And they had to stop it because they were hurting too many people with hypoglycemia. So we just can't control the sugars tight enough in sepsis to not hurt our patients. There have been other studies to show that tight glucose control in post-op patients decreases the rates of surgical wound infections. But the question then becomes, how tight is tight? Trying to keep for 80? Well, you're going to fry brain cells. Shooting for 180? Well, that may be a wee bit much for infections. What the golden mean is, I do not know. But the take-home message is not to let the patient run sweet enough that they attract ants, but rather keep the sugars low, normal, but not horribly so. I just think this is interesting because so many of my colleagues don't seem to believe in hand washing. Now, this was not a hospital study. This was a study that looked at diarrhea in the third world. But they found that simple hand washing with soap and water would probably reduce diarrhea spread by 30%. This is a Cochrane review, and there are quality reviews of medicine. But they looked at all the randomized controlled trials and estimated that if you just did soap and water hand washing, you could decrease a significant number of diarrheal illnesses, which accounts for about 2.2 million deaths a year in children. Diarrhea, shitting yourself to death, is still a major cause of death in the world because of lack of clean water and lack of simple hygiene. So next time you walk into a patient's room and you don't wash your hands when you come out, just remember that metaphorically, you're killing an African baby. I hope you feel good about yourself. The two most common questions I get are, what do you treat a patient with and how long do you treat a patient? My eldest son, who hears a lot of my cell phone calls in the car, says that the only thing I ever recommend anymore is vancomycin. So, if you want to know what to treat the patient with, give them vancomycin. How long is interesting, and usually the duration of therapy in infectious diseases is determined by the number of fingers on your hands, i.e. 10 days, or the number of days in the week, some multiple of 7 or 14 or 21. Now, this was a study in the pediatric literature and the surgical literature, neither of which do I normally report in this podcast. They looked at 149 patients who had perforated appendix. They were randomized either to a prolonged course of intravenous therapy or were rapidly switched over to oral therapy and found that both groups had a similar rate of intra-abdominal abscess rate, i.e. 2 in each group. So rapid conversion to PO antibiotics in the pediatric population was beneficial in perforated appendix. Warning, warning, it was retrospective, not prospective, not randomized controlled, but still. The old saw about cryptococcal pneumonia would be that in normal hosts you don't need to worry about it, and that in abnormal hosts you need to worry about dissemination. This may not be entirely true in this day and age, at least here in the Pacific Northwest, with the new hypervirulent strain of Cryptococcus gattii that's up in Canada. Not Candida, but Canada, the country, not the yeast. Anyway, what happened in this study was they looked at the significance of serum cryptococcal antigen in patients with solid organ transplants and found that if they had a cryptococcal pneumonia but they also had a serum cryptococcal antigen that was positive, they were more likely to have extrapulmonary disease. Now, in a transplant patient with a cryptococcal antigen or cryptococcal pneumonia, you're going to be treating them anyway, but you should probably go looking for cryptococcal meningitis even if they're asymptomatic if you have a transplant patient with cryptococcal pneumonia and a positive serum cryptococcal antigen. Again, ID is the coolest subspecialty in all of medicine, and this next article shows why. Now, for years, people have been diagnosing Plasmodium malariae in Southeast Asia. However, it turns out that there's another Plasmodium called Plasmodium knowlesi, Knowlesi, that looks just like P. malariae. However, unlike P. malariae, which is relatively benign, this organism has a high turnover, it multiplies every 24 hours, and causes high-grade parasitemia and death in this part of the world. The other interesting thing about Plasmodium knowlesi, assuming I'm pronouncing that right, is that it occurs in monkeys and can be spread from monkeys to humans and back by way of mosquitoes. So unlike other malaria, which tend to be very specific for human beings, this organism can be spread back and forth from monkeys by way of the mosquito. Now, is that not cool? Now, it responds to chloroquine. It's not a resistant organism, but its distribution may be much greater than we know. And if you have a case of parasitemia that looks like P. malariae, it's probably P. knowlesi. So if you happen to be traveling within the range of the long or pigtailed macaque and you get a mosquito bite, think about Plasmodium knowlesi rather than Plasmodium malariae. Them Cochrane folks are at it again this time looking at the difference between using tap water versus saline for wound care. Now, this tap water has to be drinkable tap water, so that rules out Los Angeles, whose water I think has too much minerals in it. But they did the usual meta-analysis and found that when using tap water, they had no difference in the outcomes compared with using saline. For chronic wounds or acute wounds, the amount of infections were the same, and in fact, it might have been slightly better to use tap water in acute wounds in adults who have infections. They found no difference, though, overall in the use of tap water, and it's certainly cheaper than buying saline at the store. And here in the Great Pacific Northwest, where we have the most delicious Bull Run water from the melt off of Mount Hood, it probably is imbibed with all sorts of magical entities that will increase your healing. Now, the problem with tap water, of course, is it's contaminated with homeopathic medications. The problem with homeopathy is the more you dilute a solution, the more powerful it becomes. So all those people that have dumped their homeopathic medications down into the water supply, it's now super potent water, and who knows what kind of side effects you'll get from using tap water on a wound. The penultimate study here concerns voriconazole and was published in the Clinics of Infectious Diseases, and they did voriconazole levels in their patients, and this both decreased toxicities and it increased efficacy because multiple patients had subtherapeutic levels, and by increasing their voriconazole, they got on top of the invasive fungal infections. To quote from the abstract, liver disease, age, genetic polymorphism of the cytochrome CYPTC19, which I believe is a Star Wars droid, and comedications, actually it's comedications, but it looks like comedications to me, influence voriconazole metabolism. In other words, when it comes to voriconazole, you can't trust how much they're getting in. So checking levels may be a beneficial way to treat patients, and certainly if you have failure of your therapy, make sure they have enough voriconazole in their blood. Whether that's a practical utility at your hospital or mine, I have yet to determine. And finally, in our It's the End of the World as I Know It and I Feel Fine department, I commend everybody's reading the IDSA's public policy article, The Epidemic of Antibiotic-Resistant Infections, a call to action for the medical community from the Infectious Disease Society of America. And I just quote here from the abstract, quote, "The result of insufficient federal funding, more money, insufficient surveillance, prevention, and control, insufficient research and development activities, misguided regulation of antibiotics in agriculture, and in particular for food animals, and insufficient overall coordination of U.S. and international efforts could mean a literal return to the pre-antibiotic era for many types of infections." End quote. I see the future and it ain't purty. There we go. That ends our content at the 29:25 mark of this podcast. I'm staying within my self-imposed limitations of 30 minutes. And so ends another Persiflagers podcast for the last 2 weeks of January 2008. References, including some not mentioned in the podcast, are available at the website, www.pusware.com. This is CME accredited. Now that you've done this, take the online quiz and get a free half hour of CME thanks to Legacy Health System. Brought to you by Pusware LLC, the publisher of the Persiflagers Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion. Your Uber hyperlinked electronic guide to infectious diseases at pusware.com. I would like to take this opportunity to thank everybody who has written such nice reviews of my podcast on iTunes. It actually means something. I shed a tear. And if you like this, listen to the Quackcast, a review of supplements, complementary, and alternative medicine, i.e. scams, also available on iTunes. Don't forget, if you're a medical student who wants to become a doctor, we have a great internal medicine training program here at Legacy. And don't forget my wiki, idwikibook.org. So far, it's languishing in obscurity, and I anticipate it will continue to do so. But if you want to add to the overall knowledge of the world, please go there and add to the knowledge of the world. Seems pretty simple. Bandwidth ain't free, so if you'd like, purchase the compendium and support this podcast. This is copyright under the Creative Commons license. My email, of course, is on the website, and as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, goodbye.